Okay, hello everyone. So let me just check, am I audible so that we can start the session? Hello everyone. Okay, hello everyone. Yeah, so it's all audible and I was just checking whether I was audible or not. So we can start the session. So welcome to the e-Gurukul MDS, DBMCI e-Gurukul, and I would like to tell about the most important things which will be covered today in this session. Okay. Okay, so let's start with the rapid rewind of top PYQs for your NEET PG examination, which is highly important for you. So let's start with that. So I like to start with the first MCQ. So basically, what is very important for this session is basically required. So if I am talking about the most important aspect of this session is that most important questions will be discussed. Okay. So basically in this session, most important questions will be discussed, which will be highly beneficial for you in the examination. So I just want everybody, okay, so here Sankalp Sinha is there, Tanvi is there. Good evening, dear. Good evening, dear. So for the maximum benefit of the session, so that you can have the maximum benefit of the session, what I want that we should have the discussion of most important question being asked in the previous year of examination. So I have targeted the most important questions and the topics. So let's start with this first question. So this was also from the previous year. This was of 2020 three examination paper. Which anatomical structure, so this was from 2024 examination paper. So which anatomical structure passes through the structure marked with a black arrow in the image below? The option given is internal laryngeal nerve, external laryngeal nerve, recurrent laryngeal nerve, and that of inferior laryngeal artery. So actually students, I am seeing the screen, I am seeing my own screen and it is absolutely clear. So I just want everybody, please check your internet connection because I am seeing my own screen. I am also seeing this in the mobile. So the screen is absolutely clear. Okay. Is it okay? Sankalp Sinha, is it okay? Is it okay? So if I enlarge this image, you can see this is the green color structure. So this is exactly the green color structure, which is the thyroid membrane. So this green color structure is thyroid membrane. And we have to know the nerves and the vessel which is piercing it. This was a previous year question and I want that you have to mark the right answer. So Sankalp, is it okay for you? You are able to see the screen? Yes, ma'am, the screen is fine. So here Core is telling the screen is fine. So I think Tanvi, you have to check with your internet connection. Okay. So you can mark the right answer and the hint which I have given to you is the green color structure is thyroid membrane. Okay. So basically thyroid membrane which is connecting the thyroid cartilage and the hyoid bone is having a pierce, one nerve and one artery is piercing it and you have to give the right answer. So here I want you to so basically I want to come up with this explanation so that you can mark the right answer. So when I am talking here in this part, you can see correctly the important aspect. So I will just use this view template. Okay. Is it okay? Okay. So here I just want everybody to see this image. This structure which you are seeing here, let me slightly enlarge. This structure is the thyroid cartilage. What structure is this? This is the thyroid cartilage. So this is thyroid cartilage and this is the hyoid bone. Which bone is this? This is the hyoid bone. Yes, good evening. Good evening, Gotwami. So you can see the membrane which is connecting, the membrane which is exactly connecting it. The connection is to be seen. So if we will see the connection is between the connection is between the thyroid cartilage and that of hyoid bone, and the structure, the vessels. So we have got a nerve and artery piercing it. So the nerve is internal laryngeal nerve and the artery is superior laryngeal artery. That means the correct answer will be internal laryngeal nerve, which is piercing thyroid membrane, and the other structure which is piercing is the superior laryngeal artery. So that gives us the right answer. So definitely the right answer will be internal laryngeal nerve in this case. What will be the right answer? Internal laryngeal nerve in this case. Now, what is thyroid membrane? As I told you, it is connecting the thyroid cartilage and the hyoid bone. And if you will see the thyroid membrane, it is thickened in the midline to form median. It is forming median thyroid ligament in the midline, and on lateral side it is forming lateral thyroid ligament. The membrane, the piercing of thyroid membrane is done by one nerve and one vessel. The name of the nerve is internal laryngeal nerve and the name of vessel is superior laryngeal vessels. Now, can we move on to the next important question? A rapid recapitulation. So let's talk about the second one. A person comes after RTA, road traffic accident, with blindness. On MRI, we can see an aneurysm which is at the location of optic chiasma. So which of these vessels is most likely the common cause of aneurysm? So the site has been given and the site is optic chiasma. So we are knowing that the site is optic chiasma and aneurysm is at the level of the optic chiasma, and we have to see that which of this artery is the reason for the compression of optic chiasma. The option which is given is anterior communicating artery, posterior communicating artery, anterior choroidal artery and the middle meningeal artery. So anyone can give blindly the guess, and these are the questions from the previous year of examination for your NEET MDS examination. So you can give me the answer there. Anterior communicating artery is absolutely right answer. Actually, it is the anterior cerebral artery and also anterior communicating artery will be the right answer. If I have to choose one of the option among the option given here, I will go with anterior communicating artery as the right answer. Absolutely correct, Dr. Sujay Singh Goswami. So here, vascular compression, if I am talking about the vascular compression which is happening at the location of optic chiasma, so the defect which will be seen in this case will be a bitemporal field defect by the compression of optic chiasma, and generally the aneurysm of the arteries which is causing this condition is ACA, anterior cerebral artery, anterior communicating artery. Okay, and also ICA, internal carotid artery. So among the option which among the aneurysm of the artery which can cause this lesion, we have got three arteries: ICA, internal carotid artery, anterior communicating artery and anterior cerebral artery. Yes, Aditi Huda, anterior communicating artery is absolutely right. So we will pick the right answer as anterior communicating artery. Now I also want you that the major region of optic chiasma compression is that of pituitary adenoma. So pituitary adenoma is the reason of compression of optic chiasma, and the defect which is seen here is bitemporal hemianopia. Bitemporal hemianopia as shown. Here you can see the optic chiasma is compressed by the case of the pituitary tumors. Now, posterior communicating artery is not the right answer, because if you will see the right and the left posterior communicating arteries, they are more towards the base aspect of the brain, not exactly at the level of optic chiasma. Anterior choroidal artery. We know that anterior choroidal artery is a branch of ICA, internal carotid artery, and it is the internal carotid artery which can compress or form aneurysm at the optic chiasma level and compress, not the anterior choroidal branch of ICA. Middle meningeal artery is also not the right answer. If I am talking about middle meningeal artery, which is a branch of maxillary artery, it is mainly related to the pterion, lateral aspect of the skull, and it is not related with that of optic chiasma location. So basically, it will be main trunk will be injured at the skull base fracture, or it can extend where it is extending to the foramen spinosum. Now coming to the next question, question number 3. A patient has got pain on turning neck to the left and his chin deviates to the right. So basically, for example, if I'm turning the head to one side and my chin is seeing the other side, this is exactly the movement of one muscle. So exactly this movement, what is the question is telling about the movement. The neck is turning to one side. So I'm moving the neck on the one side and I'm rotating the chin to the other side like this. So this is exactly the movement, and this movement is done by which of the following muscle, whether the muscle is platysma muscle, whether the muscle is anterior scalenus muscle, trapezius muscle, or sternocleidomastoid muscle. So I want a right answer. So I have got, so many of the students has already given the answer. It's Pawar, Mahant, Goswami, Aditi Huda, Joshi. All of you have given an excellent answer, and a thumbs up goes for you. So all of you have given excellent right answer, and the correct answer is sternocleidomastoid muscle. This is the action of sternocleidomastoid muscle, which is called as sideway gauge. Now, actually I want you to tell that there is a nerve, that is the spinal accessory nerve. We know that accessory nerve means the 11th cranial nerve, and the 11th cranial nerve is having two components, two parts. One is the cranial part, another is the spinal part. So when I am talking about the spinal part of the accessory nerve, it's the spinal accessory nerve, which is giving innervation to two muscles that is forming the boundary of posterior triangle of the neck. So we have got sternocleidomastoid muscle and the trapezius muscle. Both of these muscles are innervated by spinal part of the accessory nerve, that is called as spinal accessory nerve. Actually, whenever any procedure is done in the posterior triangle of the neck, if you will see the course of spinal accessory nerve, it is traversing between the two layers of deep cervical fascia. What are that two layers? We have got investing layer and we have got prevertebral layer. These are the two layers of deep cervical fascia, which is investing layer is forming the roof of posterior triangle of the neck. Prevertebral layer is forming or covering the floor muscles of the posterior triangle of the neck. And we have got spinal accessory nerve traversing exactly between the investing and prevertebral layer of deep cervical fascia, and it is giving innervation to two muscle, SCM, sternocleidomastoid and trapezius muscle. Sorry, the action which is described in the question is about the action of sternocleidomastoid muscle. So the muscle being injured is sternocleidomastoid muscle. See this image, the accessory nerve is giving innervation to two muscles, as you can see in this image, and the muscles are, this is the sternocleidomastoid muscle and T for trapezius muscle. Now I would also like to tell you about the action or the function of sternocleidomastoid muscle. So when I am talking about the function of sternocleidomastoid muscle, it is rotating the head to opposite side. So it is rotating the head to opposite side and obliquely rotate the head. So it also have got another action of flexion of the neck. So when, for example, when there is bilateral contraction of sternocleidomastoid muscle, you flex the neck, you extend the head, and if one side or unilateral contraction of sternocleidomastoid muscle occurs, the head rotates to opposite side and flexes laterally to the same side. So this is exactly the action which I am performing. This is the action of sternocleidomastoid muscle. The nerve supply is spinal accessory nerve. Now, why other options are not correct? Yes, Goswami, you are right. Wry neck to the condition. Yes, wry neck is absolutely right. It is seen in, we have got different kinds of wry neck when there is an injury of the nerve. Yes, you are absolutely right, Goswami. Now, if I am talking about the platysma muscle. Now, platysma muscle is a muscle which is located in the content of fat of the superficial fascia. So, it's an example of panniculus carnosus muscle. So platysma is a very small is a muscle which is on the in the neck region, and this is forming wrinkles in the neck. So it forms wrinkles in the neck. So it is not the right answer. If I am talking about scalenus anterior muscle, which was one of the option given, we know that scalenus anterior muscle, if there ipsilateral contraction of scalenus anterior muscle, it will primarily relate in the result in lateral flexion of the neck of the same side and elevation of first rib during the forceful inspiration. That means it is involved as a muscle of inspiration, accessory muscle of inspiration, and it also results in lateral flexion of the neck. Trapezius muscle is also not the right answer. Actually, spinal accessory nerve is giving innervation to trapezius muscle also, but if I am talking about trapezius muscle, its upper fiber is causing elevation, it is elevating the scapula. It is also have an other function of retracting the scapula or depressing the scapula. So it is also the other muscle which will be affected. But what was the action which was given in the question is not coinciding with the action of trapezius muscle. So we will not mark trapezius as the right answer. Is it okay? Let's move on to the next question. Secondary centers of bone growth are located at. Secondary centers of bone growth are located at apophysis, epiphysis, diaphysis and metaphysis. Secondary centers of bone growth are located at which location? This was also a previous year question recently asked, I think in 2023 examination. So please mark the right answer here. Epiphysis. So I am getting a multiple answer and absolutely correct here. Yes, epiphysis is the right answer. Secondary centers of bone. So if I am talking about the parts of the long bone, it is having metaphysis, diaphysis, epiphysis. So secondary center of ossification is located in the epiphysis part of the long bone, and primary center of ossification is located in the diaphysis or the shaft part of the long bone. So basically the right answer will be epiphysis. Now, in long bone, the secondary centers appears in the epiphysis. Now, at the end of formation of secondary ossification center, the only two areas where the cartilage remains is the articular cartilage, where the epiphysis and the epiphyseal plate lies between the locations. So that is important. That is at the ends of the bones we have got epiphysis. Now, this is the part of a long bone in which you can clearly see here in this diagram, you can clearly see that this is the proximal epiphysis, this is the distal epiphysis, this is the diaphysis, which is the location of primary center of ossification. This epiphysis will be the location of secondary center of ossification. And the epiphyseal end of diaphysis is called as metaphysis. Apophysis is wrong. Why? Because apophysis are growth zones which are attached to the shaft of larger bone. So secondary ossification center is not located in the apophysis region. The apophysis region varies with the development and their own ossification centers, and this is not the correct answer. Diaphysis is the middle part of the long bone. It is the shaft part of the long bone, and it is the location of primary center of ossification, not the secondary center of ossification. Metaphysis. If I am talking about the metaphysis are the wide portions of the long bone and the regions of long bones where the growth occurs. If I am talking about the growth to occur in this zone, it is in the section. Metaphysis is actually the it is the epiphyseal end of diaphysis, and it is located exactly between the diaphysis and metaphysis, and metaphysis is the most vascular zone of the long bone. Now coming to the question number 5. A full-term child is born with unilateral cleft lip. The parents are very anxious and want to know the reason for this deformity. The embryonic basis for this defect is failure of fusion between which of these following processes? Option A, failure of fusion of lateral nasal process and maxillary process, failure of fusion of frontonasal process and maxillary process, failure of fusion of medial nasal process and maxillary process, failure of fusion of lateral nasal process and maxillary process. So here I got an answer from Gautami, waiting for the others too. This was also the question of previous year. So exactly, if I am talking about cleft lip and cleft palate, a very important topic for MDS exam. So please go through this topic, developmental aspect and the embryology along with the defects. Okay. So I am getting multiple answers. So medial nasal process and that of maxillary process is the right answer. Those who have given medial nasal process and maxillary process have given the right answer. So if I am talking about the case of unilateral cleft lip, the unilateral cleft lip will be resultant of failure of fusion of medial nasal process with that of maxillary process. So quickly, I would like to recapitulate you with the cleft lip. So we know that cleft lip occurs in upper lip and it is a common condition seen in 1 in 1000 live birth. And basically, we have got different varieties of cleft lip and various varieties. So I would like to tell you about the different varieties. So basically, unilateral cleft lip occurs where there is non-fusion of maxillary process with the medial nasal process of same side. Bilateral cleft lip due to the failure of fusion of maxillary process. Entire maxillary process is not fusing with frontonasal process. Central cleft lip or hair lip occurs when there is failure of development of philtrum of the upper lip, and very rarely the two mandibular process is not fusing, and this will form lower cleft lip. I want to show you the image of this. So here A is the unilateral cleft lip, B is bilateral cleft lip, this D is the cleft lip of lower lip, and median cleft lip, hair lip is the C option. Failure of fusion. So one of the option was given, failure of fusion of lateral process and maxillary process. Actually, this is not the right answer, because if there is non-fusion of lateral nasal process and maxillary process, it can lead to the condition of oblique facial cleft to develop. Also, failure of fusion of frontonasal process and maxillary process is not the right answer. The reason is that this will lead to bilateral cleft lip. Failure of fusion of lateral and maxillary process. If I am talking about lateral and maxillary process, it will definitely lead to a condition of oblique facial cleft. Now, can you give me the other right answer? Parathyroid gland develops from. So, please mark the right answer. Parathyroid gland. Yes, Nikes Maheswari. It is due to defective formation of premaxilla and the component, okay, which is containing the incisor teeth, okay, that is containing, Nikes, that is containing the incisor teeth. So that is in stage primary palate and secondary palate, and development and defect you have to know about. Now, parathyroid gland develops from first branchial pouch, second branchial pouch, fourth branchial pouch, or branchial cleft. So, various answers are coming. Actually, yes, absolutely correct. Fourth branchial pouch or pharyngeal pouch is the right answer. Actually, why this is the right answer, I will tell you. Actually, they have not mentioned whether it is superior parathyroid gland or inferior parathyroid gland. So if it is not mentioned, we will the correct answer can be. So if I'm talking about this condition, so we can either go for fourth or third pharyngeal pouches. So it was not given. So we will definitely mark as fourth pharyngeal pouch as the right answer. Okay. Is it okay? Yeah, you are right. Yes, dear. So basically, fourth pharyngeal pouch or third pharyngeal pouch, both can be the answer, but they have not asked about the parathyroid third or fourth. So I just want that it has been asked several times in the previous year of examination. So please have a quick recapitulation of the pouches, pharyngeal pouches, and the structured form. So when I am telling that it is the when I am telling that it is the first pharyngeal pouch, the structures derived from first pharyngeal pouch will be auditory tube, eustachian tube, which is also called as pharyngotympanic tube, or the middle ear cavity. If I am talking about the second pharyngeal pouch, it will form the lining of palatine tonsil. The third pouch will form the inferior parathyroid gland and thymus gland. The fourth pouch will form the fourth or the superior parathyroid gland and ultimobronchial body, C cells. Next question. Okay, yes, if third is given or fourth is given. So basically, yes, Tanvi, if third and fourth parathyroid gland is given. So basically, third and fourth, it will be not given, it will be given inferior. It will be given either inferior parathyroid gland or it can be given superior parathyroid gland. So inferior from the third pouch, third pharyngeal pouch, and superior from the fourth pharyngeal pouch. Okay, is it okay? So this was for Tanvi. Is it okay, Tanvi? Now, injury to Tyrion affects. Injury to Tyrion affects which structure? Middle meningeal artery, MMA. Very good. Yes, middle meningeal artery is the right answer. So actually, Tyrion is a H-shaped suture. It's a H-shaped suture where four bones are meeting. The four bones. So middle meningeal artery, which is a branch of maxillary artery, is injured at the level of Tyrion if a direct blow is on the lateral aspect of the skull, and it can lead to the condition of extradural or epidural hematoma. So it can lead to the condition of extradural or epidural hematoma. Now you can see this image where you can see at the level of H-shaped suture, four bones are meeting. F for frontal bone, P for parietal bone, T for temporal, and S for sphenoid bone. So you can see here we have got four bones meeting at this location: frontal, parietal, temporal, and sphenoid, and this injury can lead to extradural hematoma, that is bleeding from middle meningeal artery anterior trunk. Okay. Now other options are wrong. Actually deep cerebral vein, anterior cerebral vein, middle meningeal nerves are not related to the level of Tyrion, so they are wrong. Also the stem of lateral sulcus or Sylvian sulcus is related to the level of Tyrion in the inner aspect. Everyone, can we go to the next MCQ? Question number 8. Okay. Skin over the angle of mandible is supplied by greater auricular nerve, lesser occipital nerve, posterior auricular nerve, marginal mandibular nerve. Skin over angle of mandible anterior to, so skin over angle of mandible anterior to ear, this area is having innervation by which of the following nerves? So yes, multiple answers are coming up. Yes, great auricular nerve is absolutely right. Yes, actually, if I am talking about the entire face, it is getting innervation from three divisions of trigeminal nerve. So it is giving innervation from three divisions of trigeminal nerve: ophthalmic, maxillary, and mandibular. Only the area anterior to ear near the angle of mandible is getting innervation from great auricular nerve, which is having the root value C2 and C3. See here. Skin over the angle of mandible, superficial fascia parotid gland is supplied by great auricular nerve, branch of cervical plexus, and the root value is C2 and C3. Actually, trigeminal nerve and its three division, ophthalmic, maxillary, and mandibular, is importantly, it is giving innervation to entire area of the face except the area anterior to the except the area anterior to the ear or near the angle of mandible, which is getting innervation via great auricular nerve. So you can see we can have this supraorbital, supratrochlear, branches of ophthalmic, other branches of maxillary. So this O for the ophthalmic region, the middle area is the maxillary region, and the lower face area is the mandibular region, which is giving the entire. So this is the whole area of the face which is getting innervation from the three divisions of the trigeminal nerve. This whole area is received innervation by three divisions of trigeminal nerve shown by the three colors. Only the area around the angle of mandible or just anterior to that of ear is receiving innervation by great auricular nerve. So there is another image for this. So you can clearly see in this diagram, if I enlarge it. So in this diagram, you can clearly see that the great auricular nerve is giving innervation near the angle of mandible here anterior to the ear, which is getting innervation from great auricular nerve and not by the three divisions of trigeminal nerve. Posterior auricular nerve is the wrong answer here, because posterior auricular nerve is actually not supplying innervation in this area. They are ascending between mastoid and back of external acoustic meatus. It supplies the occipital belly of occipitofrontalis. It is giving motor supply to the following structure. It is supplying occipital belly of occipitofrontalis muscle, auricularis posterior, auricularis superior muscle. Occipital nerve hooks around the spinal nerve, and it is innervating the upper one-third of cranial surface of auricle and the head. So it is mainly giving innervation to back of auricle. Now, if I talk about posterior auricular is wrong option, I have already told you. Marginal mandibular is also the wrong, because it is crossing the body of mandible to supply muscles of lower lip and chin. So it is also giving motor supply. It is also giving motor supply. So it is not the right answer. Okay, everyone, are you understanding? Okay, let's move on to the next question. That is question number 9. Abduction of vocal cord during respiration, which intrinsic muscle is involved? Lateral cricoarytenoid is involved, thyroarytenoid is involved, posterior cricoarytenoid is involved, or vocalis is involved. So here the action which has been asked. So abduction of vocal cord. What has been asked? Abduction of vocal cord during respiration, and we have to mark the right answer. So definitely the right answer is, most of you have given the right answer, posterior cricoarytenoid, because it is the only one abductors of the larynx. So I just want that my dear students have a quick recapitulation of the movements of the larynx and the muscle responsible for these movements. Abduction of the vocal cord. Actually, posterior cricoarytenoid is the only one muscle which is abducting the vocal cord. So only it is called as life-saving muscle. Now, abduction of vocal cord is done by posterior cricoarytenoid. Adduction of vocal cord is done by following muscle: lateral cricoarytenoid, transverse arytenoid, and oblique arytenoid. Opening of larynx is the activity of thyroepiglotticus muscle. Closing of larynx is done by aryepiglotticus muscle. The tensor of vocal cord is cricothyroid muscle. Relaxation of vocal cord is done by thyroarytenoid and vocalis muscle. Okay, dear? Correct? So this is the quick recapitulation of the muscle action of the larynx, intrinsic muscle of the larynx action, important for your upcoming exam. Now, lateral cricoarytenoid is wrong because they are adductors of the vocal cord. Thyroarytenoid are relaxation, and vocalis are also the relaxation of the vocal cord. Now, which of the following is not a branch from the third part of maxillary artery? Maxillary artery is an important branch. It's a terminal branch of external carotid artery. It is divided into three parts by lateral pterygoid muscle, and you have to know the branches from individual part of maxillary artery. So please mark the right answer, whether it is A, sphenopalatine, supraorbital, B, C, infraorbital, and D, greater palatine. So everyone is giving B, and B is absolutely right answer. Yes, dear, B is absolutely right. Absolutely correct. A thumbs up goes for everyone. Everyone has given absolutely correct right answer. Yes, everyone has given a right answer. Actually, maxillary artery has got, so if I'm talking about the maxillary artery, first part is giving 5 branches, second part is giving 4 muscular branches, and the third part is giving 6 branches. And we have to know the name of all the branches. Okay, so there are many mnemonics for it. I will explain it. So basically, if I am talking about supraorbital artery being the right answer, because it is not a branch of maxillary artery, it is a branch of ophthalmic artery, and ophthalmic artery is a branch of internal carotid artery. Internal carotid artery. So if you will see this image, you can clearly appreciate, if you are going to see this image, you can clearly appreciate that if I am talking about maxillary artery is an important content of infratemporal fossa. When the deep dissection of infratemporal fossa is done and lateral pterygoid muscle is visualized, we can see the lateral pterygoid muscle being the key muscle of infratemporal region, dividing the maxillary artery into 3 parts. The first part of maxillary artery is giving 5 branches, and you can remember by the mnemonic MADA. M for middle meningeal artery, A for accessory, M for middle meningeal artery, A for accessory middle meningeal artery, I for inferior alveolar, D for deep auricular, and A for anterior tympanic artery. Second, 4 branches are given and all are muscular branches. So how you are going to remember? All are muscular branches to adjoining areas: deep temporal, pterygoid, buccal, and masseter. 6 branches are given from the third part, and most of the branches are having the name P attached to it. P, so PI, 5 P and I. So here P for posterior superior alveolar, palatine, greater palatine, pharyngeal, artery to pterygoid canal, sphenopalatine, and also infraorbital. Okay, so these are the branches. So there are 6 branches from the third part of maxillary artery. Okay, okay dear. So all of you please memorize, this branch. It is very, very important for you to know. Okay, it's very important for you to note down. Now let's talk about the next question. So before that, sphenopalatine is the terminal branch of maxillary artery third part, so it's not the right answer. Okay, infraorbital is a branch from the third part of maxillary artery, so it's not the right answer. Greater palatine is also a branch from the third part of maxillary artery, so it's also not the right answer. Okay. Now let's talk about the next question. Question number 11. Coffin corner is junction of hard and soft palate, posterior pillars, Hodges pillar, posterior pharyngeal wall, retromolar trigone. Okay. So we have got an answer, that is retromolar trigone is absolutely correct answer. Yes, this is actually the right answer, coffin corner. So basically the other name of coffin corner is retromolar trigone. It is also called as retromolar trigone. So the name which is given to coffin corner is, it is also called as sump area. Actually, why this is the right? So sump area or coffin corner is located at the posterior tongue or floor. It is located at the posterior tongue or floor of the mouth and is a common site of cancer, but may be missed by inspection. And it is very important that during any procedure, close examination should be done in this area. Okay. Okay. So basically, it's very important that coffin corner is composed. If I am talking about the location, it is composed of It is composed of retromolar trigone, exactly, and it is the exact area located in relation to ramus of mandible, buccal mucosa, and the parapharyngeal space and the infratemporal fossa. So basically, if I am talking about the boundary for retromolar trigone, this area is located in relation to ramus of mandible, buccal mucosa, parapharyngeal space, and the infratemporal fossa. So I just want you to show exactly behind the third molar. So that means it is lying in the region posterior to the last molar tooth. So I just enlarge this and you can see the retromolar area. This is behind the last molar in relation to buccal mucosa, last molar. You can see this is the last molar. Behind that, this area is retromolar trigone. One more image is there in which you can see a photograph has been taken. So a photograph has been taken for the normal retromolar triangular area posterior to last molar tooth. Now, junction of hard and soft palate is not the right answer. It is palatine fovea is present. Posterior focal pillars are peritonsillar space lies there. Posterior pharyngeal wall also, actually this is also not, contraction of this sphincter will produce passavant ridge which will merge with, so posterior pharyngeal wall contraction of will lead into the stimulation of passavant ridge which merges with superior constrictor muscle. Question number 12. Which muscle is supplied by ansa cervicalis? Which muscle is supplied by ansa cervicalis? Stylohyoid, omohyoid, scalenus anterior or genioglossus muscle? What is the muscle supplied by ansa cervicalis loop? Please mark the right answer. So actually, if I am talking about ansa cervicalis loop, the right answer will be omohyoid. All of you, omohyoid is the right answer. So those who have given B, they have given the right answer, omohyoid. Actually, all the infrahyoid muscle is supplied by the ansa cervicalis loop. All the infrahyoid muscle is supplied by ansa cervicalis loop. Can anybody tell me which infrahyoid muscle is not supplied by ansa cervicalis loop? Yes, yes, Ahana and everybody is right. Can anybody tell me which infrahyoid muscle is not supplied by ansa cervicalis loop? Thyroid, yes, Kriti Sharma, absolutely correct. Yes, this can be twisted like this. Question can be twisted like this. Absolutely correct, dear. So you can see here C2 and C3. C2 and C3 is forming the inferior root of ansa cervicalis loop. C1 is forming the superior root of ansa cervicalis, and thyroid is a muscle which is supplied by hypoglossal nerve, C1 running along with the hypoglossal nerve. The infrahyoid muscle supplied by the ansa cervicalis loop, which is lying in the anterior wall of carotid sheath, are sternothyroid muscle. We have got sternothyroid muscle, we have got sternohyoid muscle, and that of omohyoid muscle. Stylohyoid is not the right answer because stylohyoid is supplied by facial nerve. Scalenus anterior is not the right answer because it is supplied by ventral rami of C4, C5 and C6 spinal nerve. Genioglossus is supplied by hypoglossal nerve, so it is also not the right answer. Now let's solve the next one. Can we go to the next MCQ, everyone? Nami, Ahana, Kashyap, Aditi, Pawar. Killian's dehiscence is outpouching of oropharynx, nasopharynx, laryngopharynx or trachea. Okay, checking your answers also. Please mark the right answer, dear. Okay, so laryngopharynx, absolutely correct. Yes, laryngo, actually, basically, it is not exactly. I just want you to make it clear that it is actually not exactly the outpouching of laryngopharynx, but it can be at the location of laryngopharynx. So, there may be a gap between two muscles, the two muscles, that is thyropharyngeus and cricopharyngeus muscle fibers of the pharynx, and this gap is referred as Killian's dehiscence. This gap is referred as Killian's dehiscence. So basically, if I am talking about Killian's dehiscence, it is not exactly a triangular area of gap or weakness in laryngopharynx. It is correlated with thyropharyngeus and cricopharyngeus muscle. But among the option given, we will definitely mark laryngopharynx as the most correct answer. Among the option given, if I have to mark the most correct answer, I will mark laryngopharynx as the right answer. The location is in the posterior wall of laryngopharynx above esophagus. So only we have marked this as the right answer. Description: triangular area of weakness which is lying between the cricopharyngeus and thyropharyngeus muscle. Thyropharyngeus is the propulsive part of the muscle which is supplied by recurrent laryngeal nerve, cricopharyngeus. So basically they are supplied by recurrent laryngeal nerve. Now oropharynx is not the right answer because it is basically lying in the posterior part of oral cavity, which is not not related to Killian's dehiscence. Nasopharynx is the area where nasal cavity open, and trachea is lying on the front of the neck. It is also not related with Killian's dehiscence. Neck space bounded anteriorly by alar fascia and posteriorly by which prevertebral fascia. So can you tell me which area is lying between alar fascia on anterior aspect and prevertebral layer on the posterior aspect? The option given is prevertebral space, alar space, dangerous space of the neck, or pretracheal space. So please mark the right answer here. So Kriti, Deep, Ritika, Sujav Singh, Libra, Nami, Josie, Samira, Ahana, everyone has given the right answer, and the right answer is dangerous space of the neck. Now, I just want everybody to concentrate on this image where you can see the yellow color space is retropharyngeal space, and posterior to retropharyngeal space, we have got danger space of the neck. So, danger space of the neck is lying between alar fascia on the front and prevertebral fascia on the back. If I am talking about retropharyngeal space, it is lying anterior to the danger space of the neck in between alar fascia and that of buccopharyngeal fascia. Retropharyngeal space is the most important tissue space around the neck. It is a potential space lying between the buccopharyngeal fascia on the anterior aspect and perivertebral fascia or alar fascia on the posterior aspect. It contains loose connective tissue and it can communicate with parapharyngeal spaces. Danger space is lying posterior to retropharyngeal space. Please don't get confused. Retropharyngeal space is separate from the danger space of the neck. Prevertebral space, if I am talking about prevertebral space, it is located between vertebral column and prevertebral fascia of the deep cervical fascia. Okay, so it is wrong. Alar fascia is the alar space is so thin, so it is not generally affected in infections, and paratracheal space, which is actually located, if I am talking about pretracheal or paratracheal, they are more or less similar, only it is located along the trachea, and it is also not called as the dangerous space of the neck. Next question: which of the following is a feature of unilateral recurrent laryngeal nerve injury? Laryngeal spasm, hot potato, voice, respiratory stridor, hoarseness of voice. Okay, Dr. Libra is telling, ma'am, please repeat retropharyngeal space. See here. See this diagram? Dr. Libra, please see this diagram. See here. If I am talking about pharyngeal space. This space is lying between alar fascia and bucopharyngeal fascia. Bucopharyngeal fascia. That means yellow colored space is the retropharyngeal space and it is lying anterior to the dangerous space of the neck. Dangerous space of the neck is between alar fascia and that of the prevertebral fascia. And anterior to alar fascia, we have got retropharyngeal space. So, alar fascia and bucopharyngeal fascia are the two fascia which is the location in between we have got retropharyngeal space. Is it okay? Dr. Libra, okay, dear? Dr. Libra, okay? Let's move on to the next question. Which of the following is a feature of unilateral recurrent nerve injury? Hoarseness of voice, respiratory stridors, hot potato voice or laryngeal spasm? So the right answer is hoarseness of voice. Absolutely correct. Absolutely correct. Yes. So basically when there is unilateral recurrent nerve injury, this will lead to a condition or sign and symptoms will be the patient will have hoarseness of voice and dysphonia. Vocal cord immobility will be there. Coughing and micro aspiration will be there. Okay. These are clinical features. Please highlight these are the clinical features of unilateral recurrent nerve injury. Now, when the recurrent nerve injury is injured, the hoarseness will become permanent. Paralysis of one or more muscles of larynx will lead to hoarseness of voice. Hoarseness is a temporary condition in case of external laryngeal nerve injury. But when recurrent laryngeal nerve injury happens, there is hoarseness of voice is permanent in that condition. Respiratory stridor is not the right answer because respiratory stridor, there will be actually there will be high pitched breath sound produced by the turbulent airflow and partially blocking the level of glottic, subglottic and the supraglottic trachea. If I am talking about hot potato voice, this is the condition which is seen when there is obstruction in the glottic area above the vocal cord. And generally the cellulitis and peritonsillar abscess is the reason of formation of hot potato voice. Laryngeal spasm, in this case sudden spasm and decreased contractibility of the muscle lead to larynx muscle lead to laryngeal spasm. Moving to next question. In lower motor neuron lesion, facial nerve lesion, what will be the sign and symptom seen? Contralateral paralysis of lower face, ipsilateral paralysis of lower face, paralysis of whole face, paralysis of upper and lower face of the same side. What is the right answer there? So basically when there is lower motor neuron lesion, ipsilateral paralysis of one half of the face will happen. So D is the right answer. I think many of the students has given the right answer. And again a thumbs up goes for you. Facial nerve paralysis occurs due to injury or disease condition infranuclear fibers, infranuclear facial paralysis due to low motor neuron type of facial paralysis. Now you can see the upper part of the face is receiving supranuclear fibers from both part of the brain cortex. So only in upper motor neuron lesion, upper part of the face will not be involved and it will lead to the condition of paralysis of lower face opposite half. So only one quadrant contralateral side will be involved. In lower motor neuron lesion, ipsilateral half of the face will be involved. Contralateral paralysis of lower half seen in upper motor neuron. Paralysis of whole face is a rare condition and ipsilateral paralysis of lower half, one half ipsilateral will be the right answer. Now identify the muscle fiber. Can you see this image? Please identify the muscle fiber, whether it is skeletal muscle, tendon, smooth muscle fiber or cardiac muscle. So I got an answer from Kriti, Dr. Libra. Absolutely correct. Smooth muscle fiber. So muscle fiber is spindle shaped. The muscle fiber is spindle shaped and nucleus is in the center. So definitely the picture represent a histological image for the smooth muscle fibers. So spindle shaped morphology and nucleus in the center. Myogenesis of smooth muscle, the myocyte, so basically we have got the mesenchyme cells derived from the splanchnopluric mesoderm leading to the formation of spindle shaped cell, nucleus in the center, myoblast, differentiation takes place and the muscle fibers are formed. If you will see, the smooth muscle is spindle shaped, the skeletal muscle is striated, multiple nuclei is there, cardiac muscle is also striated, but it will have IC, intercalated disc, and it will have the center nuclei, not in the periphery. In case of skeletal muscle, the nucleus is in the periphery. Skeletal muscle fiber is derived from somite, is not the right answer. Tendon is also not the right answer. And cardiac muscle fiber will have intercalated disc present. Which muscle forms the part of buccinator mechanism? Please mark the right answer. Which muscle forms the part of buccinator mechanism? Middle constrictor muscle, inferior constrictor muscle, superior constrictor muscle, or palatopharyngeus muscle? Superior constrictor is absolutely the right answer. Definitely, yes. This is the right answer for this buccinator mechanism. So, buccinator, if I am talking about buccinator trumpet muscle along with orbicularis oris and pharyngeal constrictor, together they will form buccinator mechanism, which is involved in swallowing, suckling, chewing, vowel pronunciation. Buccinator is a very important muscle playing a role along with orbicularis oris superior constrictor muscle in swallowing mastication. So it adds in mastication by compressing the cheek inwards. Okay. The cheeks are mainly, the cheeks are directly continuous with the lips and basically is the principal muscle of buccinator. Posteriorly, the buccinator lie edge to edge with the superior constrictor muscle forming the part of pharyngomandibular raphe covered by buccopharyngeal fascia and pharyngobasilar fascia. Middle constrictor is not the right answer because it is actually a muscle which is related to greater and lesser horn of hyoid bone. Inferior constrictor muscle having two component thyropharyngeus and clyptopharyngeus is not also forming the part of buccinator mechanism. Actually, they are attached to cricoid cartilage and oblique line of thyroid cartilage. Palatopharyngeus muscle derived from palatine aponeurosis is also not a part of buccinator mechanism. Now, which among the following condition occurs due to defect in formation of neural crest cells during embryonic growth? Which amongst the following condition occurs due to defect in formation of neural crest during embryonic development? Down syndrome, mandibulofacial dystosis, CLCP. CL means cleft lip, cleft palate, Parry-Robin syndrome. Yes, mandibulofacial dystosis is absolutely right answer. Treacher-Collins syndrome. Treacher-Collins syndrome. Mandibulofacial dystosis is due to the reason of neural crest migration defect during embryogenesis. So one of the syndrome which is caused due to the underdevelopment of first pharyngeal arch is called as mandibulofacial dystosis, first arch syndrome, Treacher-Collins syndrome. Treacher-Collins syndrome is an autosomal dominant condition, include bilateral symmetrical malar and mandibular hypoplasia along with the abnormalities in the neural crest cells migration. So if I am talking about mandibulofacial dystosis, this is caused by autosomal dominant gene. And the defect which is seen is the underdevelopment of zygomatic bone, cheekbone, downward slanting palpable fissure. There is defect in the lower eyelid. There is also deformities of external ear and there is also deformities of middle and internal ears. Now, the gene which is associated, so we have got TCOF1 gene, that is treachercholine Frenchity 1 gene associated with the production of or protein that is called as prickly protein is found in the biosynthesis of involved in the ribosomal RNA, which is contributing to the development of bones and the cartilages. So if there is mutation of this TCOF1 gene, it will be associated with the treachercholine syndrome, first arch syndrome, due to the defect in the migration of neural crest cells. Down syndrome is not the right answer. Why? Because it is due to the defect of trisomy 21. The major sign and symptom is the person will have, the baby will have impaired physical growth, moderate intellectual level, slanting eyes, asymmetry of the skull. See, cleft lip and cleft palate are associated with many other syndromes, and it is a it has got multifactorial inheritance as seen in Perry-Robin syndrome. Perry-Robin syndrome is an autosomal recessive disease associated with hypoplasia of mandible, cleft palate, and defects of ear and eyes. So after this, it is quite clear to us that the correct answer will be that of the cranio-mandibulofacial dystosis, the first arch syndrome, that is due to the defective migration of neural crest cells. B, mandibulofacial dystosis. So yes, dear students, we have done with today's session. And before ending, I just want that this was, actually I have taken the questions from the last 3-year NEET PG papers, the important question being asked, and a quick recapitulation was done. I hope the session is useful for you. I want a single advice which I want to give everyone, all the best firstly, and then I also want that please go through all the question being asked in the last 5 years of NEET PG exam and also for the for INICT examination, because and important topics also. Also in the upcoming session there will be a doubt clearing session which will be taken by me for the anatomy subject, and I want the students to get their doubts of the question being posted in the Telegram group before the session, so that I can prepare the PPT and give you a relevant explanation with a good diagrams. And I want everybody to go through all the question being asked in the previous 5 years of INICT and that of the this NEET PG exam. That will be very, very useful for you. So I also want to give thumbs up for all of you, because most of you have given the right answer. Get your doubts clear right itself when the session is going on. Otherwise, you can also get connected with the faculty in charge of a particular subject. For anatomy, you can tag me for your anatomy related doubt and I will definitely solve it, and definitely write itself at that time, or otherwise after some time or in the another day when I see the messages. This was helpful. Thank you so much. All the best, and my best wishes are with you. Okay. Sure, you are going to crack the examination. Just have a good sleep before the examination. And again, we are meeting with a doubt clearing session, so that you will have all your doubts clear right itself when the session, before the examination. And best of luck to my dear students. Thank you so much. All the best, my dear students. All the best. I am just ending the session. Thank you. We'll meet in the next doubt clearing session. That is on anatomy session is in the evening. I think 7 to 8 or 8 to 9 will be the timing. 7 to 8 is the timing. 7 to 8 p.m. 22nd December. All the best. Thank you.